Hello and welcome back to SPT with J and Z. I'm Zach Carson.
I'm Josh Griffin.
And this is episode 7 of our little video series here. We just finished up week 9 and we're actually going to be covering week 8 and 9 in this video since we skipped last week. Pretty easy story about why we skipped last week. We got kicked out of our lab spot because
I didn't schedule the correct time. That was my fault. I didn't schedule the correct time at the library, so
at least we didn't get interrupted mid-video.
Yeah, that would have been bad.
There was nothing wrong with that. But so we are going to cover 2 weeks worth of material. However, the 1 week we're just going to be talking about our practicals in our PT examinations course, and 2 of the classes we're going to be kind of just breezing through, making it relatively quick. It should be relatively similar in length. Couple of updates before we get going. Michigan won, Missouri won, so we're both pretty happy with our college football teams this past weekend. The World Series is knotted at 2 games apiece. Justin Verlander will be taking the mound next for the Astros, so looking forward to that. Grand Valley won again, so I think they're 7-2 on the year, 6-2 or 7-2.
They're in good shape.
After getting beat by Ferris, that was unfortunate, but overall pretty good week and weekend. Actually, pretty good last 2 weeks. Things that we have looking forward to this week: we have a kinesiology lecture and practical exams on Tuesday through Thursday, so we'll be covering a little bit of that. But let's just jump right into the topics and the course material that we missed, and we'll drive forward.
Okay. All right, so I'll take off with anatomy again. In week 8, so a couple weeks ago, we finished up lecture talking about the muscles of the eye, their innervation and vasculature. That was really just wrapping up before our exam. We had our exam, I guess, about a week and a half ago on Wednesday. So we had our lab practical, or our lab exam and the lecture exam on the same day. And then this past week, we moved on to talk more on the neck muscles. We've talked about the pharynx, the cervical plexus, a lot more on the thyroid, even though it was on the previous exam as well in the lab, but now we're getting into it more with the lecture. The layers of fascia within the neck, structures and vasculature in the neck, and then now we're moving on down into the thorax and getting more into the viscera within this unit. Moving right on to professional topics. The past couple of weeks we've started doing SOAP documentation. So we've had the objective and subjective working in that. It's used for common language with other PTs and other health professionals. It's talking about documentation through like examinations. So we have an assignment coming up on Tuesday that we'll be doing in that one. So that's really brief for those 2 courses. Moving on to evidence-based practice.
Yeah, I'll cover EBP. One thing I just wanted to mention was the SOAP note acronym is subjective, objective, assessment, and plan. So it's just an acronym for how the note is to be written, correct? And then you kind of break it down into those sections and then follow that flow. And then there's a lot of other subtopics that go into those different topics
So
also.
we've only gone through the first 2 of that whole method. So.
Okay. Cool. So in evidence-based practice, we talked more. We took a look at the study that we covered with it was an Audette. It was an article by an author named Audette, and it was the cervical range of motion device. So the CROM, otherwise known as, essentially it's a glasses rig that you rig up, and it's got dials here, a dial here, and then a dial that goes up and over on the head. You put a magnet on your neck also, so it can measure your flexion, your extension, your lateral side bending both ways, and then your rotation of your head. So it's a pretty good device. And then we went through that and we broke it down with an appraisal form. We talked about statistical significance, reliability, and then some strengths and weaknesses of that study. So the good thing about that study was that it took that CROM device and it measured it against the fast track, which essentially is like a motion analysis device where you had the capture sensors here, and I forget where they're at, but there were capture sensors on the head and neck where they could measure the range of motion. So it's considered the gold standard, which in any study, if you're going to measure against something, it always should be whatever is considered the gold standard. So in this case, cervical range of motion was that fast track device. The CROM did prove to be reliable And also there was an intra-tester reliability mechanism where the tester measured one day and then 48 hours later at the exact same time, they came back and made the same measurements, and it was found to be reliable in the sense of being able to test and retest that device. So we talked a little bit about validity, which is the degree to which the meaningful interpretation can be inferred from the measurement. So was it valid? Was the measurement valid? And yes, with that gold standard, it proved to be valid because the numbers were relatively similar. There were no statistical differences. And then we broke it down a little bit further. Face validity, does it appear what it's supposed to measure, what it intends to measure? And again, the answer was yes. We also noted that a valid test must be reliable, but a reliable test may not always be valid. So what we talked about there was kind of like the dart comparison. So it had the dartboard, and it was kind of like the whole accuracy versus precision. If you're throwing on the bullseye, you're accurate and precise. If you're off the bullseye, but all your darts are in one targeting location, or as that would be precise, right? But not accurate. And then you can have not accurate, not precise, where the darts would be all over the board. Then we went down into the effectiveness and efficacy. So effectiveness is the extent to which an intervention produces desired outcome under typical conditions. So is it the intervention producing the results that you are intending it to produce? And efficacy was the extent to which an intervention produces a desired outcome under ideal conditions. So clinical versus ideal is kind of the separating factor there. So obviously, as a physical therapist, we're going to be dealing in the clinic. So not every piece of research or intervention that we implement is going to be ideal to the conditions, but it might be ideal to the clinic. So we have to use the resources that we have in the clinic. Not so much of like, oh, we can't use that because we're not in a laboratory setting, but we have to use what we need in the clinic. We talked a little bit about sample sizes, and then if the sample's too small, it may be underpowered. You obviously always want to have more numbers to prove reliability and validity. And then the 5 and 20 rule of thumb. So if there's a 5% dropout in any study, it can lead to bias. And if there's a 20% dropout, there's a serious threat to validity. So you want to eliminate anything above 5. So 5 and below is kind of where you want to live. And then the last thing I want to cover here is statistical power. The likelihood of a study detects an effect. There is one to be detected. So if stat power is high, the probability of making a type 2 error or a false negative goes down. And then if stat power is low, the opposite is true. So the last thing I'll just touch on is the false positive versus false negative. False negative.
Hey.
Just kind of talking a little bit too fast. So false positive, false negative. I think the picture she gave us was a doctor looking at a pregnant woman and saying, "You're not pregnant."
Yeah, I think
Well,
that's right.
that's a false negative because clearly the woman is pregnant. And then the false negative was like the doctor looking at the male and saying he is pregnant, and it's like clearly this isn't. So how reliable is your research to say the stats to show that you're getting the right information out of your research? So you want to eliminate those false positives and false negatives, which I had a little chart in the slides, but I don't have it right now. So that's pretty much all we covered with evidence-based practice. We'll keep rolling forward, and we're going to go right into
Clinical
science
All right.
with Josh.
So the past couple of weeks, we've been looking at immunity for the most part. Some factors affecting immunity, there can be intrinsic factors and extrinsic, or intrinsics which within you. So it could be the medications you're taking, your personal genetics, or if you're aging. Extrinsic are things not necessarily in your control, like your environmental exposure, like if you're in a place that has a high pollution, like if you're in a city or around toxic chemicals, that can affect you. Nosocomial infection, that's where it's healthcare acquired infection. We get that because those diseases that live in the hospitals are more resistant. And iatrogenic infection also occurs in healthcare environments, and that occurs due to medical procedures where you can get an infection from the procedure itself. Things that can help kind of fight sickness is exercise. It's a big one that is overlooked, I think, most often.
Most powerful.
I love it, and it keeps keeping us healthy so far. So moderate exercise, so it doesn't even have to be all the time. So you're going moderately. It's going to increase your natural killer cells and help in stress modulation, which for me has been huge in staying sane through physical therapy school. Because high stress, you got to continue to be active and help release with cortisol and epinephrine. So intense exercise though can be dangerous. You're overworking your body, so you could end up having a decreased lymphocyte concentration from that. As a physical therapist, when we have a patient come in that maybe have an illness, we do what's called a neck check. So if they have symptoms such as like nasal congestion, if it's above the neck, anything that's like due to their sickness, if it's above the neck, we can continue to do exercise, but we're going to do it at a decreased intensity at first. And if they stay the same through that short time, or they actually do better, then you're going to continue. But if they get worse, then you stop. And then the rule of thumb is if the symptoms are below the neck, then we don't exercise them. So moving on, the immunodeficiency diseases that we talked about, we have two different types, which are primary immunodeficiency. This doesn't allow for production of T cells or B cells, and this one's actually highly deadly. Whereas a secondary immunodeficiency, you can live with these. One's a leukemia, and the other is like an autoimmune disease. So with iatrogenic, you can get you have radiation, pharmacologic, or you can even have a splenectomy that causes the immunodeficiency. HIV is one autoimmune disease. It's the precursor to AIDS. So you always hear HIV/AIDS. So you acquire HIV, and then once your body becomes kind of in a lower state of immunity, then you acquire AIDS, which becomes the more deadly form. With prevention for HIV, the main ones that we've always heard: abstinence, wear condoms, avoid IV drug use, so it can be passed along through drug usage. To combat this, we can also use sterile needles. So I think in some places where there's high drug usage, there's been provided sterile needles, even though that people actually are addicted to the drugs. They'll try to prevent the spread of HIV by providing actual sterile needles to combat it. The population most affected or disproportionately affected is African American population. There's a relatively high percentage of African American males in incarceration, and in these environments there's unsafe and violent sexual practices. Also, they have a presence of a sickle cell trait that makes them more susceptible to HIV/AIDS. So what happens with HIV is it invades the CD4 T helper receptors, and this destroys the helper cells and decreases the production of macrophages and B cells. Immunosuppression, so when the ratio of T4 T8 drops below 1.0, that's when opportunistic infections can begin. And it manifests with certain diseases becoming prevalent that normally wouldn't actually occur in somebody that's normally healthy at that age. So oral hairy leukoplakia, oral candidiasis, and Kaposi sarcoma are three diseases that occur kind of not due to HIV, but occur in a population that it normally wouldn't at a certain age, like I had said before. So management, there's no vaccine, but there are medications to help slow the process. People are living longer with HIV. There's some neurologic complications, like you can see gait disturbances or dementia in some. A cardiopulmonary complication would be like pneumonia or vasculitis. These things occur whenever the immune system becomes depressed. An integumentary disorder, I said Kaposi sarcoma. And the risk of transmission for healthcare workers is actually really low. It's got to be transmitted through like blood or semen and vaginal secretions are the three most common, I do believe, for that. So when we're working with patients, that really isn't an issue, especially with physical therapists.
It's a lot more common inpatient than it is outpatient
Yeah.
in the hospital environment.
All right. So another pathology I guess we could go into is like a chronic fatigue syndrome. Now, some people think they're really fatigued. Well, it's not always, you don't have to be just tired. It has to be chronic fatigue and like a malaise or just a general unwellness. You just don't feel good. That it actually limits what you actually do in real life. So if you can't be like you can't fulfill the roles of being a mom or a dad or fulfill your job duties day to day, that's what characterizes the actual chronic fatigue syndrome. Fibromyalgia, which affects a large population. This is a chronic muscle pain syndrome. Females are at the most risk, and what puts you at more risk is a prolonged anxiety or emotional stress. And then to actually be diagnosed with fibromyalgia, there are different pain tender points on the body that have to be tested, and the subject has to report pain with palpation of at least 11 of those 18 spots. And then to treat fibromyalgia, we're going to do more of a holistic treatment. We need to use exercise, but it can't be too much. It's more of a low aerobic exercise to help them out. Mm-hmm. And then moving on to infection, which was our week 9. So everything that I just talked about was through week 8. And then week 9 will be a little bit shorter here.
We covered a lot of stuff.
We covered a lot of topics and a lot of slides. So infection is invasion by and multiplication of pathogenic microorganisms within the host. Some sources are bacteria, viruses, fungi, chlamydia, protozoa, prions. An endogenous infection would be like if the agent comes from within the body. Exogenous, and you're like breathing in something, or you just happen to touch it and ingest it. That's another way. And then nosocomial infection, like we talked about before. Chain of transmission, this is just the order through it. Pathogen or agent, reservoir, portal of exit, mode of transmission, so sneezing, like airborne droplets, a mode of entry, so you're like ingesting those airborne or inhaling those airborne.
Which is the most dangerous.
Yes,
Anything
he's
airborne.
said that a million times. I think in class that if you want to transmit something, you do it through the air because it's the quickest. And then you need a susceptible host, so somebody that has a depressed immune system for it. And that would be, I think the last thing I have to say on controlling transmission is your standard hand washing, have barriers, get your immunizations, and sanitize things with PTs. Hydrotherapy is one where you can see transmission a lot because it's hard to clean out tubs, and I believe he said that PTs are using those type of sources for therapy less and less.
Yeah, like a hot tub or something along those lines.
And then gate belts would be the
which
one that
surprised me.
Yeah, so I would think, I guess it's more the cloth belts that people are using. The vinyl ones are a lot easier to wipe down and to keep clean. Yeah. So that's really all I have for the week 9, just to keep it brief. Just things that we will typically see within the clinic and just be aware of.
We should just do a whole video on clinical science.
It feels like it sometimes, the amount of info we have now. But all right, moving on to kinese. The past couple weeks, getting ready for our exam. So Zach's going to take us away to begin this one.
So we have our exam coming this week. Our lecture exam is going to be on the craniomandibular, so TMJ, kinematics. It's also going to cover shoulder, elbow, and wrist. So last week we were able to get, or our last video, we were able to get to sternoclavicular joint, and we left off on the AC. So acromioclavicular joint, glenohumeral, elbow, wrist. So I'm just going to go kind of rapid fire through the kinematics, osteo and arthro, and just talk our way through it. Feel free to interject at any point. Okay. All right, so the AC joint is by and large a plane joint. However, on the acromion, it actually has a slightly concave surface to the convex surface of the clavicle, so it kind of fits in there just like that. So we have to think about that, our joint property, our characteristic when we're talking about the kinematics, as always. Now we also have to remember that the kinematics are the scapulothoracic joint, or the scapula or the acromion, moving on the clavicle. So we're looking at a concave on a convex surface. So with that being said, the scapula moves in all kinds of different directions. It's not a true joint. It's secured by muscular attachments. So as we elevate, we have that superior roll, superior glide. As we depress, we have inferior roll, inferior glide. So same. And then the paired movement with elevation is upward rotation. So as we upwardly rotate, it's going to do the same thing, superior, superior, and then as we downwardly rotate, inferior, inferior. Now we can also go forward with protraction and to the rear with retraction. So as we protract, we're going anterior, anterior, and then as we retract, we're going posterior, posterior. Pretty simple arthrokinematics on that one. Not so simple is when we get to talk about the force coupling, which I will talk about here shortly. So that is the AC joint, and then I kind of also covered, we're talking about the AC joint is driven by the scapula, so the scapulothoracic joint is the scapula actually sitting against the rib cage, and it kind of moves in all those different directions against the rib cage. With that being said, there's a rhythm that happens through the shoulder and the arm. It's called the scapulohumeral rhythm. It's a smooth and continuous motion, the scapula moving on the thorax in response to movement of the humerus and the glenohumeral joint, so humerus and glenohumeral. And I was just talking to Josh about this as we were kind of reviewing. Everything's kind of driven down the chain of our arm. So we're not moving from the clavicle, we're moving from the humerus through the glenohumeral joint, through the scapula, through the acromion, through the clavicle, into the sternoclavicular joint. So it kind of all comes down the chain, so all the movements are driven basically distal to proximal when we're talking about this whole complex. So that scapulohumeral rhythm is a predictable manner, and the big thing is that when we're looking at like glenohumeral abduction, so we're taking that glenohumeral joint and we're abducting through that shoulder, we get about 120 degrees of glenohumeral movement before our scapula has to kick in and upwardly rotate for 60 degrees to get to our full 180. So that's where that rhythm comes in, and it talks about the advantages of the rhythm: less wear and tear on the tissues. So if your scapula is locked up and you're trying to compensate through that glenohumeral joint, you're going to get a bunch of wear and tear and stresses in that glenohumeral joint that aren't necessarily going to be favorable. It might lead to some kind of labral damage. It might lead to impingement, tendons of the rotator cuff becoming inflamed, anything along those lines. And then if anything, like I just mentioned, if anything's absent or impaired, the other things can become worn down. So then we'll go back to force coupling. Force coupling basically is muscles working together in different linear directions to provide the same movement. So we'll go back to that abduction, upward rotation movement that we were just talking about. So in order to abduct, we have to have the supraspinatus and the deltoid, get that abduction of the glenohumeral joint. At the same time, when we get here, we have upward rotation of the scapula. So the things that upwardly rotate the scapula are going to be the trapezius, middle, the upper, middle, and lower fibers all working together in different directions, and the serratus anterior pulling that angle out this way. So I mean, we have all these different muscles working basically in different directions around the scapula to produce the same motion. So obviously that's just one example, but there's a ton of other places in the body where that happens, largely around those ball and socket joints that have a ton of movement that require a lot of stabilization and opposite muscle actions to make sure that that joint remains stable. So we'll go into glenohumeral kinematics now that we covered the AC and the ST joint. So glenohumeral is going to be a primary movement, is going to be a spin movement, because we have this big convex surface moving on the glenoid cavity of the scapula, which is a concave surface. So the primary movement is actually going to be a spin movement. In reference is going to be the lateral aspect of the greater tubercle. So as we go into flexion, we get an posterior spin We get a movement around the body of our humerus, which is simply going to be anterior into superior into, actually when we get into full flexion, it's actually going to slightly move posterior. So since we have that concave on convex relationship, the glide is going to go in the opposite direction. So it's going to be an anterior, like once we get here, we're anterior roll, posterior glide. We get here, we got superior, inferior, and then once we get here, we're actually going posterior, we have an anterior glide. So extension, again, that references the greater tubercle. We get that anterior spin, posterior roll, and anterior glide. And then abduction, adduction, again, superior, inferior, and then when we come back, we have inferior, superior. And then rotation, also anterior, internal rotation is anterior roll, posterior glide. External rotation, posterior roll, anterior glide. Easy enough?
Oh yeah,
There's a lot of stuff there, but if you just think about the joint characteristics, it's pretty simple to actually reason your way through these movements. It's just when you have to start pairing them and moving down the chain that you have to really start comprehending what's going on. So let's move down to the elbow quickly. I guess I could say quickly, but it might be a little less than quick because the elbow consists of several articulations. We've got our humerus, we've got our ulna, and we've got our radius. So that means we have an ulnohumeral, we have a radiohumeral, we have a proximal radioulnar, and a distal radioulnar. So it's not a true hinge joint because actually as we flex that ulnohumeral joint, because of the shape of the trochlea, is going to also abduct or adduct. So as we flex, it adducts, which means we're going to have the anterior or superior roll of the humerus with the superior glide because of the concave on convex rule. But then we're going to have a shift. So we have adduction, a medial shift, or a medial roll with a lateral shift on the trochlea, and then just the opposite in extension. Now with that being said, the radiohumeral does the same thing, so it follows the ulna, anterior, and then medial, lateral, and then opposite in extension. But the radiohumeral has the spin aspect because it glides this way as we pronate and supinate, and obviously these happen in the transverse plane. So as we pronate, we're going to get an anterior spin. Again, the reference is the lateral aspect of that humeral head, and then as we supinate, we're going to get a posterior spin. Now we'll talk a little bit about radioulnar. So the radioulnar is going to be a convex on concave, basically sitting in like this. So as we pronate, we're going to get anterior spin, posterior glide. As we supinate, we're going to get posterior spin, anterior glide, and then just the opposite down on the distal radiohumeral because the roles switch. Now we have concave moving on convex, and simply we get anterior, and then posterior.
Good. That was good.
That's quick.
That was quick, but you did good.
All right, and then I'm not going to break down the wrist too much just because there's a lot of things going on, but for the most part in the wrist we have the convex rule, except for the trapeze group, the trapezium and the trapezoid moving against the scaphoid. That's just the opposite, it's the concave. So basically with the concave rule, as we roll in one direction, everything's gliding back the opposite direction, except for that trapeze group. And then with the fingers and the metacarpals, it's all concave rule, so everything rolls and glides in the same direction, which makes everything super easy, except that thumb because of its orientation. Did I get everything? Was that everything?
That was plenty.
I tried to cover it as fast as possible.
No, I think that was good.
So that's really what we're covering. It's just everything, boom, from the fingers all the way up through the clavicle, through the scapulothoracic. And then in lab this week, we just palpated the hand and wrist. So we have our lab practicals this week that covers those things. A lot of muscles in the forearm, but they all follow very predictable patterns. So if you can kind of figure out a way to spin it in your head, it's actually pretty easy to regurgitate those things. That's all I got for kinesiology. Do you have anything else to add for that?
Not for kines, no.
I'm exhausted.
All right.
I'm actually
Well, I'll start us off on foundations, and we're going to talk about our practicals and foundations to conclude. but I'm going to talk about what we just did this week, week 9. So we started on manual muscle testing on the upper extremity. And in lecture, we talked about why we actually do manual muscle testing. And this is quote straight from the slide here. So they're used to determine the capability of the muscles or muscle groups to function in movement and their ability to provide stability and support. So the info that's provided through the testing is used for the diagnosis, prognosis, and your treatment throughout. What's going to lead us to test the muscles? We might see a compensation someplace. So one looks like maybe they're hitching their shoulder when they bring it through, or something just doesn't look right. Their active range of motion may not be good, but in their passive range of motion, they can get to where they need to. So we're gonna look and say, oh, there's a muscular imbalance or inefficiency there. Their gait pattern's off, and then they may have been immobilized, so they wore a cast or something like that. So we're going to test the muscle after they get their cast off, so we can see how much we need to improve on one side versus the uninvolved side. What contributes to muscular weakness? Posture. I feel like that's a big cause for everything. Posture. Daily activities, we may use one muscle group more than the other, so some muscles are underused. Your diet can affect it. Your diet. Neurologic issues or even pain can cause. So if you have pain in one place, you're going to compensate in another, and we can lead to imbalances. To return strength, we do a lot of neuromuscular retraining, muscular development, and retraining. So the neuromuscular, it's just all combined. So when we end up testing it, we have 2 different tests. We have one joint muscular test and a 2 joint. When we test one joint muscles, we're going to put that muscle at the end range and then have them push against our resistance. And then with 2 joint, we want them to be within their mid range, because if they're too shortened, could have like a muscular insufficiency. So we want to make sure that they're within the range, so there's putting some stress onto the muscle before we test it, but not all the way. The big takeaway with our grading system is there are several different grades with it. We go from 0 to 5, that's the most commonly used clinically. Normal would be 5, and then 0 is where we're not getting any firing through the muscle whatsoever. The tricky part with this is with the 3, which is fair, and 2, in my opinion, because we have pluses and minuses with those. A fair assessment.
Pluses with all of them, right?
Well, except for 5, I guess.
Except for 5, yeah. 5
is just a flat, just 5. There's no like 5 minus or anything like that. So 4 plus, 4, 4 minus, 3 plus, all the way down to 1. I think there's just a 1 and then just a 0. So like I said, normal is 5, so the muscle can hold against the max pressure that we push on to the patient.
So put your arm out like this. Hold. I can't break them. 5.
But if he were to push down on me and I slowly release, that would be like a 4 plus to a 4 minus, just depending on how quickly I would break on that one.
It's subjective too, based on the therapist.
True. So there's a 100-pound girl therapist is probably not going to put the same force or test the same as maybe a 250-pound, just like giant dude that can really push through. It's really subjective. So as long as you're doing it consistently, that's how you can make sure that you're getting valid measures within your patient. I won't go too much into more of the grading system, but big one, normal, it won't break, so that's our 5. And then to the very opposite side of the spectrum, we have a 0, which is we can't get anything to fire through their muscle. You can't even see it twitch. So that's where we know that we have a big issue with the patient. Just for sake of time, one last thing is an important consideration when we're testing is to always, if there's pain involved, we want to make sure that we're testing the uninvolved side first, so that we can get our gauge. And then, like I said before, attention to detail in our testing. We want to make sure that we're providing the same force, testing, giving the same grades throughout, just to make sure that we have consistent data for our patient. And then, anything to add through that?
I just wanted to briefly touch on the obscure references of the scoring scale. So if you're able to get to full range and you can't hold it, so you get to full range but you immediately lose it, that's a 3 plus. So it's kind of like a weird, obscure scoring. And if you're not able to get to full range, so no matter what, if you're at partial range, say this is my full range here. If I get to partial here, if I get to partial here, if I get to partial here, but I'm not able to get to full, it's 2+.
Yes.
So it's just a little bit weird. Like I said 3- for once. I didn't say 3+, did I? So if I'm able to get to full range and I immediately lose it, that's a 3-.
Yeah.
I might have said 3+. 3-. And then if you're able to get to partial range, no matter what that partial range is, it's a 2+, until you put them into a gravity eliminated position and can further test for different deficiencies. So like those are two of the things that we've been kind of getting hit on to make sure that we know that going forward.
That's good. So whenever you get into a gravity neutral or an anti-gravity position, the most that a patient can score is a 2+.
Yes.
So that's their highest threshold once we go into a horizontal plane testing for that. So I think that covers everything. I know it's kind of all over the place, but it's definitely a difficult scale, something we're trying to grasp. And as we go into the lower extremity, we'll get more practice with that. And then testing or going through our practicals and foundations,
Yeah.
which was reflexes, sensory testing,
Range of motion.
range of motion. So we got to work with our goniometers as well.
Yeah.
I don't know about your experience. You want to just go on right into yours?
Yeah,
I'll talk about mine.
I'll jump into it. So we're just going to talk our way through the experience. So I walked in, I got a patient who had damage. Something fell on her, it was actually her right shoulder. So we immediately had to do a sensory testing, and since it was a localized, something fell on her damage, I immediately went, I'm going peripheral nerve, probably not going to be a nerve root. She doesn't have any kind of neck pain, anything along those lines, no tingling in her arm. So I went through the sensory screen on her, and it ended up being diminished light touch in the axillary nerve and absent light dull, or light dull, sharp dull.
Sharp. There we go.
But it was kind of funny because like I knew where I was going through for the peripheral nerves, and I'd be touching her here and she couldn't feel it, so I was like, all right, cool, axillary, just like I think. And then I was like, all right, she feels it here, and then I went inside the arm and she didn't say anything, and I think she just kind of got spun up in her own head. Luckily I noted that, but I was able to still isolate that area and get that right. So hit those peripheral nerves pretty well. So that was my upper extremity. And then we went into reflexes. So my partner didn't exactly have the best patellar tendon reflex, and we practiced on her a couple of times, and I was able to elicit very, very light response, maybe a 1+, every time I practiced. And I was like, all right, cool. And they always say, whatever you hope that you don't get is what you're going to get. And immediately she goes, all right, why don't you go ahead and demonstrate the patellar tendon reflex? And I was like, awesome. And then she asked for the nerve roots, which was the L3, L4, no issues there. And I'm thinking, shoot. So I immediately go into her right leg, nothing. And I'm like, all right, just why don't you go ahead and sit there for a second, check her left real quick, nothing. So then I put her through some distraction techniques and then some muscular involvement techniques. And I kind of got her laughing for a second because I was joking around with her because she knew she wasn't going to get anything and I knew she wasn't going to get anything. And I got her laughing, and actually all of a sudden her left leg, boom, fired. And I was like, whoa. We were both surprised.
Yeah.
And then I was like, hold that laugh. And I went to her right leg and I got a little reflex. So I actually graded her as a 2+ on her left and a 1+ on the right. It was the first time that I'd ever gotten anything out of her right. And her left leg was almost normal. So they were there. It just, she was very, like, I would say hypo reflexive. And not that she has any impairments or anything. She just has a lot of neural tension in her lower half, and I think that attributes to it. Because when we did like range of motion testing, she was super low in all of those things. Super lower half bound volleyball player, so she's really strong in the lower half, but not very flexible. So that was good. Ended up scoring out pretty well there, and then we went into range of motion. I had eversion of the foot, and then my upper body was a active internal rotation. Active internal rotation of the glenohumeral, and then passive eversion of the foot. No issues there. I was able to align myself with the goniometer. That is the most important part, making sure that I had the body in the right spot and that I was reading the right numbers. Couple of questions afterwards, knocked it out of the park, no big deal. I felt good with it, and it was valuable, very valuable. How's yours?
I was pretty happy with how mine turned out. I had a lot of practice going in with the peripheral and the nerve roots, and I actually got a peripheral nerve as well in the upper extremity, and I'm getting the ulnar.
Okay.
I believe, and it was a different question because I think she had an injury to like the elbow, but she had some pain in her, like it was like numb to her pinky, which within that area it made sense, and I was able to figure it out pretty quick. And with us having to act out the insufficient, like if you couldn't feel it, or like if you were supposed to feel it or you couldn't feel it, some people kind of forgot what they were supposed to do.
Yeah.
So she had a little bit of difficulty, and actually, since I knew it, I was like, no, you actually don't feel that. Yes, you do feel that one. And my professor was laughing because I already knew what it was, but I had to go throughout the full test to do like touch and sharp dull, and I was able to do that one. So that was probably what I was most nervous about, and I was able to get through it just fine. And then I still had the patellar reflex, so
Nice.
was able to elicit a response on both with a little bit of stretch on her right one, but she was 2+ for both of them.
Nice.
And then my range of motion, I had cervical extension, and then an active shoulder flexion. So I actually had some pretty easy ones, to be quite honest, and then a passive inversion of the foot. So it wasn't too bad for me. I like going first, so I always volunteer to go first and get it over with.
Knock it out of the park.
And I felt pretty good coming out of it. I got to see my score, and I passed, so I was pretty happy. So just one. It was neat. All the practicals are nice to see what you've accomplished because we put a lot of work into it, and then to see your skills be played out in a real life setting, even though it's more high stress. It's going to be high stress for the first few times when we work with a patient too. So it's nice to be put in those situations, even though we don't really want to be in a high stress situation all the time.
Right.
So, but it was a good experience. I'm looking forward to getting more of the muscle testing, or muscle testing. I guess
those are going to be tough.
It's going to be tough.
It's a lot of information.
It is a lot, and a lot of different, just anti-gravity or gravity.
Eliminated.
So a lot of positions, but we're getting to PPTs 1 week at a time. It's already week 10 now. Week 10 now.
Week 10. Going into week 10 out of 15. Is that what it is?
It's flying by, I'm not
what
going to
it
lie.
is. Yeah.
It's flying by, but
We'll get there.
we'll, I guess that's it for week 8 and 9 then.
Yeah.
All right, we'll
Anything
see
else
you.
to add?
Nope, I got nothing.
All right.
Time to go study.
All right. Well, thanks again for watching, and we'll see you guys next time.
So yeah.